Hello, everyone, and welcome to today's webinar. We will begin in about a minute, and we'll be waiting for attendees to enter the room. Thank you. All right, so we're just at the top of the hour, and I'd like to welcome everyone. This is a pre-conference webinar for the 2022 Ryan White HIV/AIDS Program Clinical Conference, and today is Wednesday, September 28, 2022. My name is Jose Francisco, and I'm a project manager at IAS-USA. We're excited to host our annual HIV 101 webinar with Drs. Michael Saag and Melanie Thompson. Dr. Saag will provide a presentation regarding the initiation of antiretroviral therapy, and Dr. Thompson's presentation will discuss primary care for people with HIV. I would now like to introduce Dr. Saag, who will go over our introduction slides. Welcome, Dr. Saag.
Thank you, Jose, and welcome everybody. I'm very pleased to co-host this webinar on initiation of antiretroviral therapy and primary care for people with HIV with Dr. Melanie Thompson, who is co-chair of the HIV/MA IDSA primary care guidelines, is a member of Thacker and Thompson in Atlanta, Georgia. So Melanie, always great to work with you. And we're going to be going over these topics with the assumption that we're talking mostly to people who are kind of new to providing care to HIV patients. And this is to provide some context and background for folks as you start your journey, which is very rewarding in the care of patients with HIV, and get you ready for the Ryan White Conference, where we're going to pick up where this leaves off and talk about what's new in HIV care. But right now, this is focusing on what's known, the basic foundation of what we do every day in the clinic. So these are the financial relationships that Dr. Thompson and I have. You can read them. It's also in the other materials. But I have gotten some grants to my institution and also serve as a consultant to TFF Pharmaceuticals and American Gene Technologies. And Dr. Thompson serves as a chair of an independent data safety monitoring board for Excision Biotherapeutics, and our institution has received grants from Cepheid, Frontier Biosciences, Gilead Sciences, GlaxoSmithKline, Merck Sharp, and Doman Vive Healthcare. This conference is funded by HRSA, the Health Resources Services Administration of the U.S. Department of Health and Human Services, under the grant that you see here, which is the AETC, and it's awarded through Rutgers University School of Nursing with a subaward to the IAS-USA, the International Antiviral Society USA. The IAS-USA is a accredited CME provider by the Accreditation Council for Continuing Medical Education to provide continuing education for physicians, and you'll receive 2.0 AMA PRA Category 1 credits for participating in this activity. We also have CME credits for nursing contact hours, pharmacotherapy credit, and pharmacy contact hours, which is equivalent to 0.2 CEUs. Those of you who are pharmacists know what that means. And also for the physicians, you can get ABIM, internal medicine, MOC points if that applies to your practice. What's nice about these webinars is that on-demand recording and slides from this webinar will be available within 24 hours after the live broadcast at www.ias.usa, and that can that will be there for you sort of in perpetuity, but for quite a while. So you can, if you want to go back and see some things yourself, you can, but of course you can refer friends. Now, we're also going to be having poll questions, and a separate window will open up, and you just choose your response on the poll. It'll be displayed after the poll closes. And so that'll go throughout the webinar. Also, if you have questions, use the Q&A button. That's at the bottom of the screen. We're going to try to get to as many of the questions and answers at the end of our presentations, and we'll just go to the time is up. But that's an important part of these events. And even though the chat is open, you can certainly use that to start a discussion with other attendees. But if you have questions, don't put it in the chat. Try to put it in the Q&A. All right, so I'll get started here. I'm a professor emeritus at the University of Alabama at Birmingham at UAB. So we're going to start with a question just to kind of orient us to who is in the audience today. You can read through these on your own, but just a sense of where you consider the primary work of what you do every day. Go ahead and vote. Okay, let's see the results real quick. Yeah, so it looks like a lot of people working at community-based health centers and clinics, and that makes sense. A few hospital-based people, some government folks, and some folks who do clinical research. So welcome, everybody. So upon completion of this webinar, as far as my talk, and Dr. Thompson will have her objectives, we're going to talk about the basic mechanisms of antiretroviral therapy and what are the regimens that might be selected based on patient parameters. So let's start with a question. This is a pretest. A 32-year-old has started on his first ARV regimen. Within 1 week, his creatinine jumps from 1.0 to 1.15 milligrams per deciliter. Which of the following drugs is most likely responsible for that increase in serum creatinine? Is it TDF, TAF, abacavir, bictegravir, or emtricitabine? Go ahead and vote. Okay, let's see. We're not going to show the answers here. We're going to, I think we're going to wait and do that at the end. I guess we'll talk about what the right answer is. I guess we can show the results and then we can talk about it. So let's, yeah. So most people want TDF or TAF. All right, we'll make note of that. And second poll question, a 23-year-old has been told she is 3 weeks pregnant. An HIV test as part of her prenatal care shows she's HIV infected and has a viral load of 12,000 and a CD4 count of 456. She has no underlying medical conditions, no concomitant medications. Which of the following do you feel is the best option for her ARV therapy? Is it fixed dose combination bictegravir, dolutegravir with TAF FTC? There'll be 2 separate tablets. Dolutegravir with TDF and FTC is 1 tablet. That'd be 3 TC actually. TDF FTC is 1 tablet, and boosted atazanavir or boosted elvitegravir, both with these last 2 options with cobicistat. Go ahead and vote. Okay, let's see what kind of results we have here. All right, most people went with option 2, 61% of people, and we'll come back to this at the end of the talk. Okay, so how do we approach people with HIV? So there's basically 3 steps. Obviously, history and physical examination with some lab tests, scanning and thinking about opportunistic infections. You can see that I'm in clinic right now, literally. But literally an hour ago, I took care of a guy who had newly diagnosed with a viral load of 7 million and a CD4 count of 2, who on evaluation had both PJP and Kaposi sarcoma. So these things can coexist. So you want to go ahead and assess for that. And that helps to determine when you might start antiretroviral therapy. And that in both of those instances, we're going to start right away and treat these other underlying conditions. And we'll also talk about what to start as we go forward here. One key thing to keep in mind is that case that I just alluded to will show is that the CD4 count does tell us a lot about a relative risk of what opportunistic infections will show up. Typically, if the CD4 count is above 200, you don't see much in the way of opportunistic infections, with the exception of perhaps zoster, which isn't all that common, or herpes simplex infection, but that occurs in people who don't have HIV as well. And you can see on the slide going from left to right that different diseases from cryptosporidium to KS, like this patient had, candidiasis, mostly oral, pharyngeal, sometimes esophageal, sometimes vaginal candidiasis, PJP, which is what this patient also had, non-Hodgkin lymphoma, PML, which is a brain disorder, usually when they're below 50 cells. And the other ones, like in our patient, it was at risk for Mycobacterium avium and CMV, although he had no eye complaints. And so you use it when to start antibiotic prophylaxis. And in this case, assuming he didn't have active PJP, we would have started Bactrim therapy as prophylaxis. Instead, he's receiving Bactrim therapy, and typically would start with steroids as well. However, with the KS, you want to be a little bit careful about using steroids, because if he develops something called IRIS, which is an immune reactivation inflammatory syndrome, steroids and IRIS don't go well with KS. It's a one exception. Steroids help for most every other IRIS, but it doesn't help with KS, actually can make it worse. That's a little sidebar clinical pearl. The viral load is something also that Dr. Thompson's going to talk to you at more length about how often, but you definitely want to get it at the beginning, and it should be drawn before you start therapy, like it was in this guy's case where he had 7 million copies. So resistance testing is something we really focused on in the 90s as a lot of regimens failed. And as they failed, you wanted to see what mutations happened that could guide your next therapy. We still see antiretroviral therapy failure some, but not very much anymore. But it is important at baseline, before you start your therapy, to get a resistance genotype, because that tells you for the future what types of drugs might or might not work. And in particular, there's one mutation called the M184V, and that mutation is associated with 3-TC or lamivudine, or FTC emtricitabine. Those are the same two drugs, but it knocks them out more or less completely. And that becomes important, as we'll talk about in a minute, when you're choosing your antiretroviral regimen. There are some other key mutations I'm not going to go over now, but if you go to the IAS-USA website, you can pull down the resistance mutation document, which explains this in great detail. Or there's even these PDF type handouts that you can look and see the common mutations associated with the different types of drugs. A phenotype is something we used to get a lot when there's complex genotypes. We don't order that very much anymore, and that's really beyond the scope of this presentation. So there's some common rules of antiretroviral therapy. You want to use more than one drug. Monotherapy is not used, even with the better drugs. So you want at least 2 drugs have different mechanisms of action, things that are easy to take to help with full adherence to therapy. You want to start antiretroviral therapy as early in the course as possible. You want to treat everyone, even elite controllers, and there's been some debate about that. Elite controllers are people who have undetectable virus at the outset. Their HIV test is positive and their viral load is undetectable, and you can distinguish whether that's a real HIV positive or not just by checking HIV DNA if you're in doubt. But even those folks with the so-called elite controllers, as their immune system controls, need therapy. For most people, some people they watch for a while, but typically over time, everyone will need it. Low viral level viremia is not antiretroviral therapy. Failure of getting an robust CD4 count response is also not ARV failure. We'll talk about both of those in detail. And then U equals U means undetectable equals untransmissible. Very important in public health for patient to person transmission, but also fits with mother to child transmission. So the mom who we just talked about in that second case that we presented as a pretest question, starting her on antiretroviral therapy, getting her viral load undetectable, will assure that the child does not pick up the infection from mom. So let's jump into the details here of what supports each of these statements. So using multiple regimens, let's go back to basics. So there's on the website at IAS-USA, there's a more detailed discussion of what I'm going through here from a prior 101 pathogenesis talk. But here's the money slide for that. So we have HIV infected cells when somebody's infected, and a bunch of resting CD4 lymphocytes, which is a vast majority of the uninfected cells. And less than 1% of cells over time in any moment can become activated. And it's those activated cells that you see in this turquoise color that are the target for the virus. During any single day, about 1 to 10 billion viruses are produced a day, every day. And over time, they come down and infect these guys, and they in turn replace the ones at the top. And that's the vicious cycle. And in fact, the cells at the top, the HIV infected cells, live on order of a day. So this constant production of virus and then loss of HIV infected cells with replacement is really the vicious cycle of HIV that gets interrupted with antiretroviral therapy. And a key point here is that the antiretroviral therapy only protects uninfected cells from becoming infected. It does nothing to interrupt or kill off these cells. So these guys die in about a day. They're replaced by these guys. So if you block mostly 100%, all the antiretroviral therapy that's worth their salt does that, you would say, okay, great. If these guys live for a day and you block this, they aren't replaced, you should cure somebody in the matter of maybe several months or a year. The problem is that about 1% or a little bit of more or less of 1% of cells in the body that are infected with HIV don't die in a day, and they have become latently infected CD4 cells that live for years. And when they reproduce, the virus goes with them as they double. So those are the cells that are preventing us from curing people. And in fact, when you stop antiretroviral therapy down at the bottom, those cells will reignite the fire by producing virus sporadically and infect those other cells. So what does full maintenance of adherence do, and what's the rationale? Well, of course, this virus wants to replicate all the time. When you have the antiretroviral therapy on board, it stops that replication by protecting the uninfected cells. So if you don't have full adherence, that replication can occur. And just like with bacterial therapy, antibacterial therapy, you can have resistance develop with poor adherence or intermittent therapy. The drugs that we use are targeted towards different steps of the life cycle. So there's drugs that interfere with binding and entry. It comes into the cell, goes from single-stranded RNA through reverse transcription into double-stranded DNA that translates into the host nucleus, where it's then integrated into the host, and then new viruses form on the surface, and new virions are produced that go on and infect the neighboring cell. It's important to remember that we have blockers of entry, a lot of reverse transcriptase inhibitors, be it nucleoside and non-nukes, integrase inhibitors, and then protease inhibitors that interfere with this maturation of the virus as it leaves the cell, so that a virus is for sure released, but it doesn't infect the neighboring cell, because the protease enzyme that's important for cutting proteins into their active components, that protease is blocked. And so the polypeptides remain as polypeptides. And even though that virus is released, it can't infect the neighboring cell. So I've already alluded to starting therapy as early as possible. And believe it or not, back in the 90s, when antiretroviral therapy was being developed, there was a huge debate about the timing of starting therapy. Those of us who were working in the lab and as knowing that story that I just told you with 1 to 10 billion viruses a day, we're kind of wondering, what's the big deal here? This virus, going gangbusters, why wouldn't you treat everyone early? But it took a little time for the debate to unfold. And these are some data that kind of convince people. This is around 2008. Mari Kitahara with the NA Accord showed that deferral of antiretroviral therapy to the CD4 count of 350 to 500, as opposed to starting when the CD4 count was above 500, was associated with a relative hazard of death of 1.7. And that was quite shocking. And some people say, oh, we don't believe it. That came from a cohort. So they organized a randomized trial that showed exactly the same thing, that the relative risk was, if you flip that 0.43 relative hazard around, it's about 1.6 to 1.7 relative risk. So the randomized trial confirmed that. The other reason biologically to start earlier is because we know that on the left-hand side, this was looking at markers of activated cells and inflammation, that untreated HIV patients have a lot of that compared to the people who are uninfected. But even people on antiretroviral therapy still have a little bit higher inflammatory marker than people who are uninfected, but much, much, much less than what people who are HIV infected and untreated. And this is what a slide I showed a lot during this debate, because if we had somebody who's 30 years old, newly diagnosed, and had a CD4 count of 650, typically we would wait till 500, excuse me, to start therapy. And that takes about 5 years, but we're talking about lifelong therapy. So when you pull back, you go, what's the difference here? If they're going to live into their 70s and 80s, we're talking about just a drop in the bucket, relatively speaking. And during that time, there's potential harm during that 5-year period. And that harm is in the form of persistent inflammation, that higher level of untreated HIV versus treated HIV. So treat everyone. And then the elite control, as I've already alluded to, because even though the immune system is suppressing the virus, it's doing so at a cost. It's the immune system is having to work to keep the virus suppressed by killing off the cells a little bit sooner, resisting the new infection of cells. And that cost over time, it's like any other chronic inflammatory condition, be it rheumatoid arthritis or even hepatitis C that's untreated, there's cost to this. So I think most of us lean towards treating them. And here's those data once again. Another way to look at it is that people that are on pre-therapy versus post, you can see it dropping down. And again, this is just the same type of data, whether you treat early or late, it's like acute infection or not, it's very important. So here's another more pretty diagram of where the entry inhibitors work, the nucleosides, the non-nukes, integrase, and protease. There's some new drugs that we'll be talking about at the Ryan White course called capsid inhibitors that interfere with the release or the disruption or the removal of the capsid as the capsid complex enters the nucleus, but it also interferes with production of the capsid. So you get two mechanisms in one drug, and those capsid inhibitors are now being studied, and one of them has been approved in Europe so far. And this is just an amazing, amazing story of drug development over the years, and more recently, starting with raltegravir, the strand transfer integrase inhibitors really are the mainstay of therapy. Lots of guidelines have been produced. There's the HHS guidelines that I'll show you data from in a second, and then the IAS-USA guidelines that are released every 2 years roughly, and usually published in JAMA. And the 2022 recommendations are currently in development and hopefully will be in press if it gets accepted. So based on that, what are the key recommendations for starting therapy? You want to start as soon as possible. We've talked about that. Remove the structural barriers. If there's things that are getting in their way, be it cost, access to medicines, getting to the clinic, focus on that. Depression, substance use also can be blocking. In the setting of OIs, you want to start generally within 2 weeks, and a lot of times at the same time at the OI is initiated. The exceptions would be tuberculosis, which generally with lower CD4 count individuals, you want to start pretty immediately. With a higher CD4 count because of IRIS, some people wait 2 to 4 weeks or so. And cryptococcal meningitis historically has been associated with potentially worse outcomes if started early. That's true for sure in sub-Saharan Africa. And in Europe and in the United States, Australia, Japan, we aren't really seeing that the same way. So starting cryptococcal meningitis therapy, antiretroviral therapy, I usually shoot for 7 to 14 days personally, but 14 days is a general rule of thumb. For folks with cancer, immediate ART initiation really kind of helps, but you got to watch for drug-drug interactions. We'll dance around that in a second. Here are the HHS guidelines. They recommend either a fixed dose combination BIC-TAF FTC or dolutegravir fixed dose combination with abacavir 3TC. With abacavir, you got to remember that there's a hypersensitivity reaction for people who have a haplotype in their genetics of HLA-B5701. That's a mouthful, but basically it's associated with a heat shock protein on, I believe it's chromosome 6, it might be 13, I can't remember, but that can be associated with when you use abacavir with an acute hypersensitivity reaction. If you stop therapy and then restart with abacavir in that setting, you can have a fatal outcome, fatal. So it's important to know about that before you start dolutegravir. Dolutegravir with either FTC or TAF TDF or 3TC. And then there's a dual combination regimen with dolutegravir 3TC, and the caveats are listed there below, that you don't want to use that with hepatitis B present because the 3TC will fail and you'll get resistance to that. So the tenofovir is key in chronic hepatitis. The data when the RNA levels are greater than 500,000 also are not there as much. It probably works as well, but we don't have the data. But so if it's above, like our guy, I would not start him on a 2-drug dolutegravir 3TC regimen. And that's also true in the CD4 counts less than 200. A lot of people will start with a 3-drug regimen, maybe simplify the dolutegravir 3TC later in some of those settings. The IAS-USA more or less is the same, except it's not recommending abacavir at the present time, at least back in 2020, and that's continuing. The bottom line is that the XTC and TXF is either FTC or 3TC is the X, or TDF or TAF, and those are drugs that go. Now, one of our pretest questions asked, what causes a 0.1 increase in creatinine? It is not the tenofovir, TDF, or TAF. It's the integrase inhibitor. So bictegravir or dolutegravir are well known to do that. It's immediate. And what it is, it's interference with secretion, active secretion of creatinine. Yes, at the tubule. We always were taught creatinine is filtered by the glomerulus. It is. But there's also a small amount of creatinine that's secreted by an enzyme in the proximal tubule called OCT2, and you inhibit that inadvertently or whatever. You inhibit that with dolutegravir or bictegravir or raltegravir to a little bit lesser degree, and that's what causes that bump. So what I'm trying to say is that it's normal. You should expect a little bump in creatinine. It is not a sign of pathology. So there are other recommended regimens. The cobicistat is a boosting agent and inhibits the CYP3A4 isoenzyme of the liver that's important for metabolism of drugs. Otherwise, the darunavir in this case will be rapidly inactivated. So the cobicistat, in essence, poisons the 3A4 isoenzyme system. Excuse me. And then there's fixed dose combinations with that. So as long as you're using darunavir or any other protease inhibitor, you want to make sure you got cobicistat or ritonavir, which is also a boosting agent. The IAS-USA guidelines recommend dolutegravir abacavir 3TC as an alternative, and the HHS guidelines as a primary. And then this new drug on the block called doravirine. It's a very potent non-nucleoside reverse transcriptase inhibitor. It's co-formulated with TDF and 3TC. but it can also be used independently with two drugs with TAF-FTC or TDF-3TC. Efavirenz, we don't use much anymore. Doravirine has more a higher barrier to resistance, where efavirenz doesn't. Raltegravir is a good drug, but a lot of times it has to be used twice a day in certain settings, or at a higher dose once a day, compared to the other protease inhibitors like dolutegravir and bictegravir. It just doesn't seem to have as much potency. An advantage of it, both of these drugs, but especially raltegravir, does not have much in the way of drug-drug interactions, not metabolized by CYP3A4, mostly metabolized by a glucuronidation and some other things, but not things that get in the way. And dolutegravir and bictegravir similarly, although raltegravir is the best in terms of minimal drug-drug interactions, especially when you're using treatment for TB and other things. And then rilpivirine, a non-nuke drug, also pretty potent, but not quite as good in comparative studies to dolutegravir or bictegravir. Some details about what to do when people are on rifamycin. This is more of a lookup. I'm just raising it for you so that you do, if you have somebody with TB, make sure you take a pause, talk to your pharmacist, go back to the guidelines, just double check what can be used. I think that's the point of the slide, not for you to memorize this. But notice again here, raltegravir is a really good agent in this setting, but it has to be used twice a day. But so does dolutegravir if you're on patients on rifamycin in that setting. Again, details matter. You're not going to memorize it from this lecture. Just know to look it up if you're treating TB. For pregnancy, we have that second question. Dolutegravir plus either TDF, FTC, TDF3TC, TAF, FTC, TAF3TC is the regimen of choice now. So the correct answer to that question is that, dolutegravir. Now, you may say, well, I heard that dolutegravir was associated with neural tube defects out of Africa, and that is true. Initially, that was the case. When small numbers were treated, there was a disproportionate number of children born with neural tube defects, but as the database grew, that signal went away. Interestingly, in 2003, same issue with efavirenz, which was the drug of choice emerging. And when efavirenz was first used in pregnant women, neural tube defects were seen when the numbers were small, and as it got larger numbers, that went away. And efavirenz during the 2000-2010 era of treatment was really a drug of choice for pregnancy. Now dolutegravir has been shown in comparative studies to be more effective. And in fact, dolutegravir with TAF-FTC has been shown to be a little bit superior to TDF-3TC or TDF-FTC. So lean towards TAF in that setting. Finishing up here, low-level viremia is not heart failure. Just going back to our model here, we know that antiretroviral therapy is 100% for de novo infection, but these latently infected cells up here, these guys can spit out virus periodically, especially if somebody came in with initially a very high viral load like the patient I saw earlier today. That means his reservoir of chronically infected cells, latently infected cells, is large in his body. And so those things periodically, if the cells get activated, will spit out a little bit of virus that can be detected. And you know that by just kind of watching. So don't stop therapy if their viral load's hovering at 60 or 65 or 80, and it stays steady. That's not failure, that's just biology. And similarly, the absence of a robust CD4 response. Here's a classic normal CD4 response. You get viral therapy initiated, virus drops precipitously and stays undetectable, and the CD4 count jumps and then stays on an upward trajectory. There are some people, though, who don't get much of a bump, and they slowly increase their CD4 count. And that is what happens when the CD4 count does not go up in that first 6-week period. My opinion, there's some controversy, but my opinion is pretty strong that increase is basically redistribution of CD4 cells from lymphoid tissue that are trapped there where a lot of the replication is happening in the lymphoid tissue, elaborates markers of inflammation that trap the CD4 cells. You stop the replication, like on the dime, the markers of inflammation are no longer elaborated. Those cells go out into circulation and you get that bump. There are some people, though, who have their lymphoid architecture probably through having the infection a long time, where it's diseased or it's disordered or disrupted. And those individuals don't get that release. But notice that that slope of CD4 increase is similar after that 6-week period. So that's a different phenomena. They just missed that bump. So don't get worried if you don't see the bump in somebody at 6 weeks or 8 weeks after starting therapy. They're just in that camp of people who don't get that bump. You can change regimens if you want, ain't gonna make a difference. You can add more drugs if you want, not gonna make a difference. Same thing is true with the persistent low-level viremia. You can intensify all you want, and you're not gonna change it because the biology is coming from those latently infected cells. Here, the biology is that you don't have that release of CD4 counts back into circulation. And then finally, U equals U, which we've already talked about. So I'm going to wrap up here and say that understanding the viral life cycle is critical to the understanding of the basis of ARV therapy. And when you understand that, then you can make these cool interpretations of what happens if there's a discordant viral load response, where it's sort of persistent viremia, or the CD4, the viral load doesn't increase or doesn't, sorry, let me start over. The viral load doesn't quite go undetectable. That's because of persistent release of virus from the latent cells, or you get a discordant CD4 count where the viral load is suppressed, but the CD4 count doesn't bump because of the lack of redistribution. ARV therapy interrupts the life cycle completely and halting most of the damage done by HIV. And that patient who I just saw today was now 4 weeks into therapy, had already been treated for his KS, feels great. They said, like, it's flipped the switch and he's back to his normal self. ARV therapy protects uninfected cells from becoming infected, but has no effect on those cells already infected. All ARV drugs target specific sites. We went over that. Initiate therapy generally with a strand transfer integrase inhibitor. That's integrase strand transfer inhibitor, abbreviated there, and 2 nukes. And on occasion, when somebody's viral load is lower and they don't have hepatitis B and they don't have resistance to 3TC, where there's an M184V, which would in essence make monotherapy with dolutegravir, then it's okay to use that. Sometimes you can use dolutegravir with a non-nuke. There's a fixed dose combination there. And the timing of therapy can be delayed with certain OIs. One drug I didn't talk about was cabotegravir. It's a dolutegravir cousin, and it can be given with rilpivirine as an injectable every initially monthly for a little bit, and then every other month. And that's an option for people who have trouble taking pills, just to complete this. So I think I'll close there with our questions again. Remember, we talked about this. Let's go back and ask now. A 32-year-old started his first regimen. Within 1 week, the creatinine increased. Which drug is responsible on this list? Go ahead and vote. I can tell you that 19% of you picked the right answer last time. Let's see how many get it right this time. Go ahead and show the results. Okay, boom, increase from 19 to 64%. Those of you might have been dozing off or not paying attention. With the tenofovir, that is not the answer. It's bictegravir because of that interference with that OCT2 enzyme in the proximal tubule, the kidney that secretes creatinine and is inhibited by bictegravir. Next. Okay, and this is a 32-year-old. Oh, sorry, I got to do that. And then this is a 23-year-old pregnant lady who has an HIV test that's positive, CD4 count is 456, viral load 12,000. Which is the best regimen for her? We talked about this. Directly go ahead and vote. Let's see how we do. Perfect. 91% got it right. You may say, well, why not use Bictegravir? The only reason we don't have enough data. So it might well work. Dolutegravir and Bictegravir are similar. A lot of people are saying if they're on a Bictegravir regimen going into pregnancy, they get pregnant, a lot of people will not change the regimen to something else, but data are pending. It'll be coming out soon, but good for you. That's great. So I'm going to now I'm going to stop sharing my slide and turn this microphone over to Dr. Thompson.
Okay, can you see my screen?
Yes.
Okay, let me see if I'm having a little trouble moving it here. Oops. Let me do this one more time. There we go. All right. So I am excited to talk about primary care for people with HIV today. This is sort of the outline of my talk, and we'll talk about the initial assessment, about vaccinations, cardiovascular risk, and a little bit about polypharmacy and frailty. And here is the pretest question. So go ahead and vote whenever you feel like it. A patient who may be at risk for anal cancer comes to your clinic, and what do you tell this patient is true about anal cancer screening? Number one, the Anchor study found that the annual anal Pap test is the gold standard for identifying early anal cancer. Number two, high-resolution anoscopy should be done only for persons with anal symptoms. Number three, treating HSIL decreases the incidence of anal cancer by 57%. And number four, all persons with HIV should be referred for high-resolution anoscopy. So go ahead and vote, and let's see what you think. Okay, and the answer is that the Anchor study found annual anal Paps are the gold standard. So that is what 50% of you have voted for. So we'll come back to that. Okay. So here we are seeing a person with HIV for the first time, having a welcoming, warm, stigma-free clinic environment, using people first and gender neutral language and preferred name and pronouns is the most important thing we can do early on in this evaluation. We need to get to know this person and establish a relationship. Talk about their work, their family, their social support, their living situation. And here's the time to talk about gender identity and sexual orientation. And importantly, we need to address the reason that this person is there to be seen. You know, maybe they have a pimple, maybe they have body aches, but we can't start talking about antiretroviral therapy before we address why they are there. And honestly, if we do not do these three things right off the bat, we'll probably never see that person again in our exam room, because retention in care is the Achilles heel of ending the HIV epidemic. And of all people with HIV, only about half are retained in care. And when we talked with people in Fulton County who had fallen out of care, the most important thing they told us was that they didn't feel comfortable in their clinic. So we want to get a lot of HIV specific history. Now that we've established a good relationship, we'd like to know when the person was diagnosed, when HIV was acquired, if they know that, what kind of past care they've had, including whether they've had any opportunistic diseases. We'd like to know what their general knowledge is about HIV. And Mike mentioned undetectable equals untransmittable. This is a very potent message and a motivator for people with HIV. We need to know their exposure to antiretrovirals, including PrEP, and all of their past antiretroviral medications and why they might have changed regimens, as well as all their current meds. And remember, supplements, over-the-counter medicines, alternative therapies, all are important. Of course, we're going to need to access their past medical records because most people don't know all of these details. And we want the resistance testing that they have had if that exists. This is also the time to talk about sexual history and gender history if we want to be able to offer appropriate care for this patient. And if there's a history of injection drug use, it's time to ask about practices, needle sharing, and do they have access to syringe services? And do they need naloxone? Do they have a history of hepatitis B or C? Now, we also need to go into the other medical history. I like to do this by organ system, and questionnaires really help a lot to move things along. I've listed just a few organ systems here that I think are particularly important. Cardiovascular disease we'll talk about a little more going forward, certainly infectious disease histories. But don't forget these age-appropriate issues like vision, hearing, dentition, and falls, because these are very important issues. For our populations, mental health and substance use issues are extremely important. And then, of course, as people age, their family history becomes more and more important. And we also want to get a vaccination history. And so there are a lot of labs that we want to get. Mike talked about some of these. I just want to bookmark that initiation of therapy doesn't have to be delayed to get the results of these initial labs. But of course, you wouldn't use a Bacavir if you were doing a rapid start because you need that HLA-B 5701. And also, if someone has acquired HIV after being on cabotegravir for PrEP, you're going to want to get an integration genotype for that person. And this is a new recommendation. Now, we also will get our routine labs, a lot of screening for infectious diseases. And I just want to flag that we really need to offer 3-site testing for chlamydia and gonorrhea. This is so important, and so many people don't do it. And we are in the midst of an STI epidemic. There are things that you probably shouldn't get, serologies for CMV and herpes, toxo only if people are symptomatic, cryptococcal antigen only if their CD4 is low. And then, of course, in some populations, there are additional tests like G6PD that are important. Now, I'm not going to read this to you, but I want to point out that during the full physical exam, we really want to focus on any signs of opportunistic diseases, infectious diseases, or comorbid conditions. And I would refer you to the HIV-MA primary care guidance, which really goes into this in some detail. Now, what about follow-up? So the bottom line is, after virus is suppressed, we can stop checking so frequently. So after it's been suppressed for a year, then you can check HIV RNA only about every 6 months, unless something is changing. And for CD4 count, we also decrease the frequency of testing after the virus is suppressed. And particularly after the CD4 count rises to above about 300. So ultimately, if the virus is suppressed for at least 2 years and the CD4 count rises to above 500, we can basically stop checking it. It's really not going to change substantially as long as the patient is stable. And I do want to point out that less frequent screening for HIV RNA and CD4 does not mean less frequent care. We still need to consider the need for frequent STI screening. We need to consider care for chronic conditions and also cancer screening. Now, let's shift and talk a little bit about vaccinations for people with HIV. Here are some resources for you for vaccination recommendations. There are a lot of vaccines that are the same or similar to the general population, like influenza and Tdap, HPV, meningococcus, of course, we are focusing on because of outbreaks in gay and bisexual men in particular. There is a new recommendation for the recombinant zoster virus vaccine, which we call Shingrix. And this is now recommended for people with any CD4 count who are 18 years of age or older. And we'll talk in more depth about the vaccines on the right. I do want to flag that there are vaccines that are contraindicated for all people with HIV. That would be the live attenuated influenza vaccine and the ACAM 2000, which is a smallpox vaccine that can be used for monkeypox prevention. There are others that are contraindicated if the CD4 count is less than 200 or the virus is uncontrolled, and they are listed here. They are basically live vaccines. So let's talk for a minute about the Jynneos vaccine for smallpox and monkeypox. We've really become familiar with this very rapidly recently. It is a non-replicating vaccine that is safe for people with HIV. It was initially given subcutaneously and now mostly intradermally for most people. But remember that you don't have full immunity until 2 weeks after that second vaccination, 28 days after the first. And it's really important to get those second vaccinations into the arms. It can be given as post-exposure prophylaxis within 1 to 4 days, but up to 14 days if there are no symptoms. And I would point out a recent MMWR that reminds us that 38% of people with monkeypox also had HIV and 68% were Black. So people with HIV should be prioritized for vaccination as well as treatment. And we need to use an equity approach to address the disparities. Now, I think we know by now that for COVID vaccinations, everybody with HIV should be vaccinated, and any of the approved vaccines would be fine. Because the response may be less, if the CD4 count is less than 200 or virus is uncontrolled, the recommendation is that there should be a third dose that is really part of the initial mRNA vaccine series, so it's not considered a booster. And then I also want to point out that the new bivalent Omicron-specific booster is also recommended for people with HIV at least about 2 months after their last vaccine. And this is really important right now. So of importance, we have new vaccines for pneumococcal vaccination. There are 2 pneumococcal conjugate vaccines, PCV15 or PCV20. Now, there are not a lot of data in people with HIV, no effectiveness data for either of these vaccines, but there are safety and immunogenicity data for the PCV15. And while we don't have clinical data in people with HIV for PCV20, there are a lot of data suggesting good safety and very high immunogenicity in people without HIV. And here are the recommendations. So for people who have never received a pneumococcal vaccine or you're not sure, give 1 dose of PCV15 or PCV20. And if you choose PCV20, then their pneumococcal vaccination series is complete. So very simple. If you use PCV15, then for people with HIV, you can give a second dose of the polysaccharide vaccine, PPSV23, about 8 weeks or longer after the first vaccine. And this is different than in the general population where you would wait at least a year. So you may want to wait until the CD4 rises above 200 in order to get a better response. Now, if they have had this polysaccharide vaccine as their only pneumococcal vaccination, you can give a dose of PCV15 or PCV20, and then they are done. Now, the minimal interval after the polysaccharide vaccine is at least 1 year. Now, what if they had the PCV13 and that's the only thing they had? Then you can give 1 dose of the polysaccharide vaccine at least 8 weeks later, or you can give the PCV20 vaccine, and that would be the end of their vaccination series. If they already have had a dose of the polysaccharide vaccine, then you're kind of committed along that path, and you would want to complete that series as you would normally do. So shifting to hepatitis B vaccination in adults. So we want to immunize people who are surface antigen and surface antibody negative, or if their surface antibody is less than 10 milli-international units per mil. And also if they have an isolated core antibody that is positive, you might want to give 1 booster and see how they respond, but most likely you're going to want to repeat the entire series. And importantly, you want to check in 1 to 2 months after that, and their antibody level should be greater than 100. Now, again, responses can be reduced if the CD4 count in this case is less than 350. So the decision about whether to wait until their CD4 count rises really depends on how much this person is at risk for hepatitis B. And you do, in any case, want to repeat the quantitative antibody level 1 to 2 months after vaccination, and that should be at least 10 milli-international units per mil. Now, what are these hepatitis B vaccines? Well, there are 4. There are 2 recombinant surface antigen vaccines, and the new recommendation is that these should be given as double doses if you're giving a 3 vaccine series. Now, if you're giving a 4 vaccine series, you can use a single or a double dose. There also is a 2-dose recombinant vaccine using the CpG adjuvant, and that is a very immunogenic vaccine and can also be used. And as well, if someone has not been immunized for hepatitis A, you can use the combination A and B vaccine in a 3-dose series. Now, what about people whose antibody levels don't rise after 1 to 2 months? And for these people, you can give a second series of a recombinant vaccine using that higher dose, double dose, and you can use either 3 doses or 4 doses. As well, you could try the 2-dose CpG adjuvant vaccine given 1 month apart. That is a very immunogenic vaccine. Now, what about cancer screening for people with HIV? Well, for the most part, it is going to be the same as for the general population, but I do want to point out cervical cancer screening, which really has cut off at less than 30 and above 30 in terms of how we want to screen people. For the less than 30 crowd, as well as for the for the 30 or older crowd, you want to do a PAP at HIV diagnosis, and then every year until there are 3 consecutive normal PAPs. And then you can move to screening every 3 years if normal. HPV testing is not recommended for those who are 30 or younger. And for those who are 30 or older, you can do HPV co-testing. And if you do that with the first pap smear and both are negative, then you can move right away to using a PAP every 3 years. Now, remember, there is no upper age for stopping PAP testing in persons with HIV, and this is different than the general population. So we'll speak for a minute about the ANCHOR trial. Anal cancer can indeed be prevented, and this is terrific news. They used high-resolution anoscopy to monitor the people enrolled in this trial, and then they were randomized to monitoring alone or to treatment of any high-grade squamous intraepithelial lesions. And it turns out that if you treated HSIL, cancer incidence was decreased by 57%, and that is really dramatic. So currently there is a recommendation for digital anorectal exams annually if people are asymptomatic. And if people have ever had receptive anal sex, then you would consider doing anal paps if you have access to high resolution anoscopy if the pap is abnormal. One of the real problems here is that a lot of people don't have access to high resolution anoscopy. And actually, the anchor study did not evaluate the utility of anal pap screening. So that was in the pre-test question. We'll see how people do on the post-test. Now, what about metabolic diseases? So the good news, as we all know, is that people with HIV are living almost as long as people without HIV, and that gap has narrowed to about 9 years. Unfortunately, they accumulate comorbidities faster than people without HIV. In fact, 9.5 years faster than people without HIV. So it's really important that we focus on screening for and managing comorbidities. And cardiovascular disease is among the most important and the most common comorbidities in this population. This is a really great scientific statement that was released by the American Heart Association back in 2019, and I thoroughly recommend that you download it and read it. They recommend that they recognize that people with HIV have a higher risk for cardiovascular events. In fact, 1.5 to 2-fold increase in some events. But importantly, they also identified HIV-specific risk-enhancing factors. And that would include any history of prolonged HIV viremia, whether people started late or they failed treatment or they were not able to adhere to treatment, if they had a low CD4 count, less than 350, either in the past or now, if they had metabolic syndrome, lipodystrophy, lipoatrophy, fatty liver disease, or hepatitis C. So these are all risk-enhancing factors. And if any of these is present, it's important to adjust our risk upward on our calculation scores, and it may be 1.5 to 2-fold higher. And so here are the new USPSTF guidelines on statins for primary prevention. They're hot off the press as of August of this year. And what they tell us is that for people between 40 and 75 who have at least one risk factor and a pooled cohort equation score of 7.5 or higher, we want to selectively offer a statin to these individuals. But keep in mind that the HIV risk-enhancing factors are not factored into this. So when we increase the risk by 1.5 to 2-fold, we'll find ourselves offering statins to people with even lower pooled cohort equations. And they did have insufficient evidence to make a recommendation for statins in people who were 76 years or older. Now, recommendations as to what to do. First of all, lifestyle optimization, particularly smoking cessation. Can't say it often enough. Very, very important. These are the statins that are recommended for people with HIV, largely because of lower drug interactions. And the recommendation is to start low and go slow. Remember that there are significant drug interactions with ritonavir or cobicistat. So it's important to monitor for side effects. So what about screening and intervening for cardiovascular disease? We talked about the pooled cohort equation. Waist circumference is a very important screening tool. It's easy to do. And this is a table that adjusts waist circumference for BMI. And it's very powerful as a predictor of events, including death. And the reference is there at the bottom of your slides. Also, coronary artery calcium score, as measured by CT scan, is important to identify subclinical disease, but only if the lesions are calcified. And I would point out that we know that coronary artery calcium scores predict cardiovascular events. And now we also know that people with HIV have higher CAC scores than people without HIV who are matched for age. So that tells us that this can be an important tool. Now, here's sort of a summary of management of common comorbidities. We talked about vaccination. Be sure to screen for liver disease, not only viral hepatitis, but also fatty liver disease. We need to pay attention to bone density and do DEXAs if people are at risk, but also address modifiable risk factors. We talked a little bit about cancer screening, STIs. I want to point out the screening for depression is very easy. PHQ-2, PHQ-9, that's either 2 or 9 questions, very easy and reimbursable. And it's really important to identify and treat depression in our patients. Substance use as well, we need to do better at screening. And I want to just throw you this resource from the National HIV Curriculum. I would bookmark this. It contains all of these screening tools for depression, for anxiety, for alcohol, for drug use, as well as a number of calculators. Let's talk for a minute about polypharmacy, because I think managing polypharmacy is one of the most important things we can do for our patients. Polypharmacy is taking 5 or more drugs, and that applies to so many of our patients. The best management is really to go through the drug list at every visit. Yeah, sorry about that. But especially after hospitalizations or after consults, because we know it's those other care providers who are prescribing all these extra medicines. We want to look for new or unnecessary drugs, including over-the-counter drugs, drugs that are given at the wrong dose or duration. We want to look for prescribing cascades, which is when you prescribe a drug to treat a side effect of another drug. Drugs that have overlapping toxicities, drug disease interactions, intrinsic toxicities, we'll talk about that in a minute, and drug-drug interactions. And I just want to say, don't guess about these. Please look them up. They are very tricky. And remember that alcohol, recreational substances, over-the-counter drugs and supplements also count. They're also important. Now, here are some helpful tools, and they are, the citations are at the bottom of the slide. And I really want to point out the HIVdruginteraction.org website from the University of Liverpool. This should be on your speed dial, very important. And why would that be? Well, here's an example. Our new friend Paxlovid, treatment for acute COVID, contains ritonavir, one of our old HIV drugs that has so many drug interactions. So how do we manage this? Look it up. Don't try to memorize this stuff. I think the HIVdruginteraction.org website is actually better than the COVID-19 druginteraction.org website, both from the University of Liverpool. And there also is a helpful drug interaction site from the University of Waterloo. Now, anticholinergic medications can be really damaging for patients. This is a terrific analysis from the UK POPPY cohort of people with HIV who are 50 or older. Unfortunately, it's heavily white and male, but I think the findings are important. In this cohort, 9% of people reported recurrent falls, and 32%, so a third of these people met frailty criteria. And it turns out that the number of anticholinergic medications was highly associated with recurrent falls and frailty. And sometimes we don't think about these anticholinergic effects of things like antihistamines and antidepressants, but this is a really important lesson for us all. We know that frailty occurs more frequently and earlier in people with HIV. In fact, over half of people with HIV are frail or pre-frail at the early age of 45 to 50. Now, I think it's important to think about frailty and to screen for frailty, and it doesn't have to be hard. Now, here's a really easy scale from the Canadians. It is based on clinical judgment, so there are no measurements or anything like that, but really it's using our observation of the patient, listening to what they are saying, listening to what their caregiver might be saying if they have a caregiver or family. And it turns out that even when people are not dependent on others for daily help, they may begin to complain that symptoms limit their activities. Maybe they feel like they're slowing down, or they feel tired in the daytime. And this is a real clue that they may be experiencing frailty. Now, I also like this SPPB, short physical performance battery for measuring frailty. It consists of 3 physical tasks that you can do in the office without any equipment. It's very easy. It doesn't take that long. And so I think this is another tool. There are many tools you could use. But I think the point here is that we think about frailty as this inexorable decline leading ultimately to death. But we need to think about frailty as something that potentially could be fully or partially reversed or stopped in its tracks if we recognize it and intervene. And the best ways to intervene are to maintain access to routine health care, to address the AIDS-related deficits like vision, hearing, dentition, to be sure people get their normal screening, to prevent and manage comorbidities, and that includes for mental health and substance use, and then to address polypharmacy and fall prevention, and increase healthy behaviors like physical activity and social interaction. Now, I can't stop talking without saying that even in 2022, stigma kills. So stigma due to HIV status, LGBTQ discrimination, anything else, age, substance use, mental health, race, ethnicity is a really important one, socioeconomic status. We as clinicians need to raise our voices because advocacy by clinicians is desperately needed, and it is so important. So I want to just ask you to find your voice and to speak up and try to eliminate stigma. Now, here are some resources that I've mentioned throughout the talk. This will be available to you. And let's go back to our pre-test question. So go ahead and vote whenever you are ready. A patient who may be at risk for anal cancer comes to the clinic. So which is true? The Anchor study found that annual anal pap tests are the gold standard. High resolution anoscopy should be done only for people with anal symptoms. Treating HSIL decreases the incidence of anal cancer by 57%. And all people with HIV should be referred for high resolution anoscopy. So what do you think? And let's see the results. Aha, so it turns out that the answer is treating HSIL does decrease the incidence of anal cancer by 57%, and that is the correct answer. And I think it's interesting that people still are answering that anal pap tests are the gold standard. The Anchor study didn't really look at the sensitivity or specificity of anal pap tests, but that is what we have. And so I suspect that's why people are answering the question this way. The Anchor study used high resolution anoscopy for screening in these patients. And that is just something that many of us don't have access to. But the important thing is that HSIL can decrease the incidence of anal cancer. Okay, well, let's move to some question and answers.
Yeah, that's great, Melanie. Thank you. I know you're going to lead us to this. I was trying to answer one of the KS questions from a provider who had to go see patients, and I accidentally put it in to David Moose's question, which was about, and I'll start with that one so we don't lose it. input into a few patients who, after being on treatment for a while, CD4 count had been in the 500 to 700 range with undetectable virus, suddenly has a drop in CD4 cells to 200 or less, but remains virally suppressed. Almost always, that is a problem with the absolute white count. So that remember that CD4 count is basically a product of a equation where you take the total number of lymphocytes times the percent CD4 cells, and that gives you the number. So if the total white cell drops, and therefore the proportion of lymphocytes drops, the percent of CD4 usually stays constant. So I would guess in that person, it'd probably be around 25, 30%. It's just mostly a factor of the total lymphocyte count going down. If you see that, so you look for other causes, chemotherapy, drug toxicity, where the white cell production is being impaired. So I'll start off with that, and Melanie, I'll turn it back over to you to lead us through the rest.
Yeah, so Mike, we had a number of questions for you that were submitted online. And I think one of them is important to address, and that has to do with long-acting therapy. And the questioner wants to know, can you use this for people who are naive to treatment? So right off the bat, can you put them on long-acting cabotegravir, rilpivirine? What do you think?
Yeah, so that term is direct to inject, and those studies are still underway. So typically what we're recommending is to start on an oral therapy, and it could be oral cabotegravir with rilpivirine to start, get them a little bit under control, and then go to the injection. But we're in this transition phase where that could become feasible. So stay tuned for that in the next couple of months.
Yeah, very, very important. I think we're going to see a lot more of that. There are a lot of logistic barriers to these injectable medications. So hopefully people will begin sharing best practices on that. So Mike, one of the issues that is really rising up these days has to do with weight gain for integrase inhibitors and TAF. So what is your approach to weight gain? Should people be avoiding integrase inhibitors or TAF if they're worried about weight for initial therapy? What do you think about that?
Well, the phenomena, as you allude to, is very real. And in study after study of cohorts in particular, it can be a significant amount of weight gain, especially in the first 6 months to a year. Does that mean not to use the medications? Well, no, because all the antiretroviral regimens have some increase in weight when you look at them. It's just that the non-nukes have a little bit less than the protease inhibitors, less weight gain than the integrase inhibitors, which have the most. And as you said, TAF more than TDF has a little bit more weight gain. Rather than sacrificing the potency and the benefit of our better therapies, what I do is, as I start people on an integrase inhibitor, especially if I'm using TAF, is I give them a heads up to watch out for weight gain and to be cognizant of that, and really just to kind of monitor what they're eating right off the bat. Because once the weight gain happens, as we all kind of learned, myself included for sure, once weight gain happens, it's really hard to lose it. So it's better to protect it up front. There is no benefit to switching therapies after the weight gain has happened. That doesn't seem to matter. Some studies are still underway to randomize towards these approaches, but it's a tough problem once it starts just to get the weight off. And so it's better to try to prevent it up front.
Excellent. So we'll give you a little bit of a break, and maybe I'll take one or two of the primary care questions.
Sure.
So what, do you recommend vaccinating for hepatitis B in patients with positive hepatitis B core antibody, but otherwise negative serology? And yes, the recommendation is that if there is an isolated hepatitis B core antibody, that person should be revaccinated. Now, you could try the strategy of giving a single dose of vaccine and then measuring the antibody. And in that case, you want to see a very high antibody level, which would be greater than 100 milli-international units per mil. But often there isn't a response like that. And often people just go to giving a full course of vaccination.
Melanie, what we might do is I can ask you a question, you can ask me, if that makes it a little bit smoother. I was going to follow up here with one of these questions from Alyssa Matias, who said, should you be doing anal paps on HIV positive females at the same time as a cervical pap?
Yeah, I think it's a really interesting question. And I have to say, when we think about anal cancer in the HIV population, we're often thinking about men. Excuse me. And actually, that is probably because we don't often ask women what kinds of sexual activity they're having. Are they having anal sex? And a lot of women do have anal sex. And so the interesting thing about HPV is that even for women who don't have anal sex, they could have HPV in the anal area. And so I think it's a good idea to do an anal pap for women who have HPV in the vaginal area. But I think we also do need to get a little less shy about asking women what kind of sexual activities they participate in.
Yeah, that's really important. Okay, there's another question or two, I guess, for me, and then I'll pop one back for you.
Yeah, so one person wanted to know, and I don't know who asked this because it was an online question, about Rapid Start. So if you're going to use Rapid Start, same day as the first clinic visit, when would you start opportunistic infection prophylaxis, or would you start opportunistic infection prophylaxis?
Well, okay, so I would define rapid start as immediately at the time of the diagnosis is made, say by a rapid HIV test that's confirmed, whatever. But we do this a lot in our emergency department. That means starting within the first day of a test. And by then you don't have the CD4 counts, you don't have the viral load, you're just kind of getting them covered initially. And so we don't know the CD4 count. I would not start prophylaxis until I had that information. If you had a sense that they had very advanced infection, I might start PJP prophylaxis with Bactrim. But for the most part, that's one of the advantages of starting early. There's some studies out of sub-Saharan Africa where immediate treatment start on the time of HIV diagnosis was associated with better follow-up, but it's a different scenario. The study that I think you might have been involved in Atlanta showed that, yeah, you could improve that a little bit, but the cost in terms of resources was pretty strong. My personal approach is get the diagnosis, have them come to clinic within 48 to 72 hours. The sooner the better in a way, but it doesn't have to be that first day. So you can get the data, you can have the test ordered from the place where the study or the test was made, the positive test was identified, and then you'd have a little bit more data when they come back. Another question that came up that I saw floating around was why was there such controversy about when to start? Right? I mean, it seems so obvious. Well, I think I planted that question because I know several of us, you included, were kind of screaming from the rooftops in the late 90s and early 2000s. People were afraid of the toxicity, the cost. Was it cost effective? They wanted more data. And so the randomized trial was done just because some folks just thought we shouldn't just jump into this recommendation without more data. I personally disagreed with that, but they did the study. It confirmed what I'm pretty confident it would have shown. Sometimes we can be proved to be wrong, but that was the nature of a spectrum of opinion, much like our politics today.
And, Mike, I think that one of the things that we learned early on was that these older medications, like AZT and so on, the older medications just didn't have the potency to be durable. And so some of the early studies that were done showed a nice benefit for people when they started AZT. In fact, improved survival. That's how AZT got approved. But also DDI, DDC, these older medicines. But they didn't last because the virus just chewed them up and spit them out because of resistance. And so I think that also made people concerned about how early to start therapy. And if you had limited treatments, are you going to throw them at people at the very beginning and then treatments fail? Or are you going to wait? And I think everything changed substantially when we had protease inhibitors that were much more potent and much more durable.
Right. And I'm sharing this slide from my presentation. Somebody wanted to see it again. Cabotegravir is not listed on this, but you can see what Dr. Thompson was just talking about, that we had slow development of drugs into the 1990s, but when viral load became available, we were able to see pretty quickly when the drugs were used, the effect. Starting about 2000, triple drug therapy was pretty common, and as you allude to, really worked a whole lot better. I'll leave this up for a few more minutes and go to a question for you about your opinion on starting statins. If a patient's less than 40, but has an LDL value of about 160 or so, maybe even a little less, what's your approach to that?
Yeah, so that's such a common question, isn't it? And I think we have to step back and look at the landscape for that patient. So if this is a patient who has a little bit elevated statin, who doesn't have hypertension, doesn't have diabetes, doesn't have a family history, a strong family history of coronary artery disease, and really all they have is an elevated LDL, then I think the main approach is really to work with them initially on diet and exercise and all those things that work but are so hard to do. So to take the lifestyle component first. Now, sometimes if there are patients who might have a risk factor too, or maybe they have a family history, I'll get a coronary artery calcium score. And I sometimes have been very surprised getting levels of 1,000, which tells you that people really do need intervention. I do think that it's important to recognize that people with HIV do have increased risk, and even some people who are less than 40. So even though I know the new statin guidelines really start at age 40, there certainly are people who are younger than 40 who do need statin therapy. And let me pivot to one of the questions that was about which statin to use, and someone mentioned pitavastatin. And I just want to also say that pitavastatin is one of the few statins, maybe the only one, that actually has had a clinical trial about its use in people with HIV. Now, it was compared to pravastatin, which is a relatively weak statin, but it showed excellent safety and it showed potency in people with HIV and really very few side effects. So I like that drug very much. But I also realize that sometimes insurance companies will put barriers and they want patients to fail every other statin before they allow pitavastatin. And, I have to say, I don't like prior authorization and I'm pretty aggressive when that happens. But I think the best statin is the statin that you can get, remembering not to use simvastatin or lovastatin, particularly with PK boosters. Those are no-nos.
I have three questions here I can knock out pretty quickly. One was that, does the creatinine rise with integrase inhibitors resolve over time? And the answer, no, because it's a direct inhibition. Are there any plans for a single tablet regimen for dolutegravir, TAF, FTC? Yeah, there is, but it won't happen till the patent's up for the TAF and FTC. So it's going to be a little while. But you can get in sub-Saharan Africa dolutegravir 3TC and TDF, and that single tablet regimen, you're sitting down, costs for 1 year, $30. $30 for 1 year of dolutegravir TDF 3TC. And then finally, do you start on pregnant women who are pregnant, like the one I showed early? Yes, you start as early as you can in therapy. I always add folate because that interferes with, that helps with neural tube closure. So if you want to minimize that risk, as you start the ARV therapy, start folate at the same time.
And, Mike, since you mentioned generic medicines, let me throw one more at you that came in online. And that is, for initial therapy, do you always start a single tablet regimen, or would you incorporate generic drugs into your initial therapy?
Yeah, so all politics is local and all coverage of medications is local. So believe it or not, sometimes it's harder to pay for a generic drug. Sounds weird, but that's the system we work in. So you hopefully have access to case managers, social workers, pharmacists who can help you work through this. But you want to pick the regimen that fits the patient, obviously. I don't think there's that big a difference between 1 and 2 drugs. So you can use single tablet bictegravir with TAF-FTC, or you can use 2 tablets of dolutegravir, TDF-FTC, TDF-3TC, which is generic, or TAF-FTC. And those are all good regimens. And I think in our clinic, probably 85–90% of all the starting regimens are those. Not sure what else.
Totally agree. So we are now nearing the end of our time, and this has been a terrific webinar. We really appreciate all of you spending your lunchtime with us. So I am going to toss this over to Jose again to give us some closing words. And I just want to say before we get out of here that we are all thinking today about our friends and colleagues and people in Florida who are looking head on into a hurricane right now, and just sending our best to all of you.
Yep.
Okay.
And thank you again, Dr. Saag and Dr. Thompson, for an excellent discussion and presentation. As a reminder to our attendees, evaluation and how to claim continuing education credits will be emailed by 5 p.m. Pacific time tomorrow. And this will enable us to review all of those that have attended today's live broadcast. For those registered for the Ryan White HIV/AIDS Clinical Conference, as a reminder, this will take place from Sunday, October 16th through Tuesday, October 18th in San Diego, California. Next, we have an upcoming webinar next week, which will provide an update on the prevention and treatment of pediatric HIV infection. If you are interested in registering, please visit our website. And we have a 30th annual update on HIV management in Chicago, Illinois in December 8th, 2022. Again, for more information on this activity, as long as other activities that we have, please visit our website. And this concludes today's webinar. Thank you.